Memory does not disappear all at once. It fades in small, quiet ways: misplaced words, slower recall, trouble holding details that once stayed put. These changes often begin long before anyone calls them a disease. I'm Dr. Warren Hung. I'm a medical doctor, and on this channel I focus on prevention and long-term health, especially the things that slowly shape the brain over years. Not dramatic events, not emergencies. The quiet influences that most people never think to question. After age 65, the brain is still active and capable, but it is less forgiving. It depends on delicate chemical signals to keep attention, memory, and judgment steady. These signals work like a finely balanced switchboard. When the balance shifts even a little, performance drops. Not suddenly, gradually. Here is where medications matter. Most people think of side effects as something immediate: dizziness, nausea, a rash. If none of those happen, the drug feels safe. But the brain does not always react that way. Some medications interfere with memory systems slowly, without producing obvious warning signs. They don't cause confusion overnight. They change how the brain works month after month. This is especially important after 65 because the brain processes drugs differently than it did at 40 or 50. Blood flow is slower. Clearance systems work less efficiently. Nerve cells recover more slowly from chemical stress. A dose that once felt neutral can quietly become disruptive. Another problem is timing. Many memory problems in older adults are blamed on aging itself, or on stress, or on poor sleep. Medications are often not questioned because they were started years earlier, sometimes decades earlier. The connection is missed not because doctors are careless, but because the effects are delayed and subtle. There is also trust. If a medication is common, prescribed often, and approved for long-term use, people assume it cannot harm the brain. That assumption is understandable. It is also incomplete. Safety does not always mean neutral for cognition over long periods, especially in older nervous systems. In clinical medicine, we see this pattern repeatedly. A person develops mild forgetfulness, nothing severe. Daily life still works. Over time, the decline speeds up. Only later does someone notice that several medications on the list affect the same brain system's attention, alertness, memory encoding. None of them cause dementia by themselves. Together, over years, they reduce the brain's reserve. That phrase matters. Brain reserve. It refers to the brain's ability to compensate when cells are stressed or damaged. Younger brains have more of it. Older brains have less. Medications that slightly dampen brain signaling may be tolerated earlier in life, but become meaningful later on. This video is not about fear. It is not about stopping medications on your own. And it is not about blaming patients or doctors. It is about understanding a risk that hides in plain sight. The question we are answering is simple and specific. Which commonly used medications have been linked to faster cognitive decline in older adults, and why does that connection exist at the level of brain function? To answer that responsibly, we first need to understand how the aging brain handles medications differently before naming any specific drugs. But before we talk about individual medications, we need to look closely at how an older brain absorbs, responds to, and clears drugs over time, and why small chemical shifts matter more with age. To understand why certain medications can affect memory later in life, we need to slow down and look at how drugs interact with the brain as we age. Every thought, memory, and decision depends on chemical messages passing between nerve cells. These messages are carried by substances called neurotransmitters. One of the most important for memory and attention is acetylcholine. Others control alertness, sleep, and emotional tone. When these systems are balanced, the brain stays sharp. When they are dampened or disrupted, thinking slows. Medications work by changing these signals. Some block them, some quiet them, some change how long they stay active. That is how drugs relieve symptoms. Pain eases, anxiety settles, sleep comes faster. The problem is that these same changes can affect memory and attention at the same time. In younger adults, the brain has a wide safety margin. Blood flow is strong, liver and kidney clearance is efficient. The brain barrier that controls what enters the nervous system is selective and resilient. If a medication slightly interferes with memory chemistry, the brain often compensates. After 65, that margin narrows. Blood flow to the brain slowly declines with age. This does not mean the brain stops working, but it does mean drug concentrations can become less predictable. A medication may linger longer. Its effects may last past the intended window. Small doses can behave like larger ones. The liver and kidneys also clear drugs more slowly. This is not disease, it is normal aging physiology. When clearance slows, drugs and their byproducts accumulate. That accumulation may not cause pain or obvious illness, but it can change mental clarity over time. Then there is the blood-brain barrier. This is the filter that controls which substances in the blood can enter the brain. With aging, this barrier becomes more permeable. Substances that once had minimal brain impact may cross more easily. Medications that were peripheral earlier in life can start to influence central nervous system function. Another key factor is sensitivity. Aging nerve cells respond more strongly to chemical changes. A mild sedative effect at 45 may become a noticeable cognitive drag at 70. This is why older adults often feel foggy rather than sleepy when exposed to certain drugs. Sleep architecture also changes with age. Deep sleep becomes shorter, REM sleep becomes more fragile. Many medications interfere with these stages. Poor sleep does not just cause fatigue. It interferes with memory consolidation, the process by which the brain stores new information. Over years, this matters. One more concept is cognitive reserve. Think of it as backup capacity. Brains with higher reserve can tolerate damage or stress longer before symptoms appear. Reserve declines naturally with age. When medications repeatedly suppress alertness, attention, or memory encoding, they reduce how much reserve remains. This does not mean medications cause dementia directly. That is an important boundary. What many studies show instead is acceleration. Symptoms appear earlier, decline progresses faster. Early warning signs become harder to notice because sedation masks them. Clinical guidelines recognize this risk. The American Geriatrics Society publishes the Beers criteria, a list of medications that may be inappropriate for older adults due to higher risk of confusion, falls, and cognitive impairment. This list exists because age changes how brains respond to drugs. So when we talk about medications and dementia risk, we are not talking about poison. We are talking about normal drugs interacting with an aging nervous system in ways that were not a problem earlier in life. Now that this foundation is clear, we can responsibly name the specific medication categories that research and clinical experience have linked to faster cognitive decline in older adults. But before drawing conclusions, we need to examine which commonly used medications show this pattern repeatedly in real-world patients and long-term studies. This is the core of the title, so I want to be precise about language before we start. When we say these medications may accelerate dementia, we do not mean they directly cause Alzheimer's disease or permanently damage the brain on their own. What long-term studies and clinical guidelines show is something narrower and more important. In older adults, these drugs are associated with earlier onset of cognitive symptoms, faster decline once problems begin, or worsening confusion that reduces brain reserve. That distinction matters. Now let's go through the 9 categories clearly and one by one. 1. Anticholinergic medications. These are drugs that block acetylcholine, the neurotransmitter most critical for memory and attention. Common examples include diphenhydramine, often used for sleep or allergies. Oxybutynin, used for bladder control. Some older antidepressants and gastrointestinal medications. Acetylcholine acts like the brain's memory switchboard operator. It helps you form new memories and stay mentally organized. Alzheimer's disease itself is marked by low acetylcholine activity. So when medications further block this signal, the effect stacks. Large observational studies, including work published in JAMA Internal Medicine using long-term prescription records, have shown higher dementia risk with cumulative anticholinergic exposure over years. This association is strong enough that these drugs are flagged in the Beers criteria. Boundary. Short-term use does not equal dementia. The concern is chronic use over months or years in older adults. 2. Benzodiazepines, anti-anxiety, and sedative drugs. These medications slow brain activity to reduce anxiety and promote sleep. Common examples: diazepam, lorazepam, alprazolam. They act by enhancing GABA, a calming neurotransmitter. The problem is that memory formation requires active brain signaling. Benzodiazepines suppress that process. Multiple cohort studies, including data from the French Packwood study and later meta-analyses, show associations between long-term benzodiazepine use and increased dementia risk. The risk appears related to duration, not short emergency use. Boundary. These drugs can be appropriate for acute anxiety or seizures. The concern is daily or nightly use over long periods. 3. Sleeping pills, non-benzodiazepine hypnotics, often called Z-drugs. Examples: zolpidem, zapaclone. These are frequently seen as safer than benzodiazepines. They are not benign for the aging brain. They fragment sleep architecture. Deep sleep and REM sleep are shortened. That matters because memory consolidation happens during these stages. Long-term disruption weakens learning and recall. Observational studies show higher rates of cognitive impairment and falls in older adults using these medications regularly. Boundary. Occasional use during acute insomnia is different from nightly dependence. 4. Antipsychotic medications. These drugs strongly alter dopamine signaling. Examples include risperidone, quetiapine, haloperidol. In older adults, especially those with early cognitive impairment, these medications can worsen confusion and sedation. They are associated with faster decline in patients with dementia, which is why guidelines strongly restrict their use. Clinical trials and FDA warnings confirm increased mortality and cognitive worsening in dementia patients treated with antipsychotics for behavior control. Boundary. These drugs may be necessary for severe psychosis. They are not cognitive treatments. 5. Opioid pain medications. Examples: morphine, oxycodone, hydrocodone. Opioids suppress alertness and slow brain signaling. Chronic use reduces attention, working memory, and reaction speed. In older adults, reduced clearance means these effects accumulate. Studies in pain cohorts show worse cognitive performance with long-term opioid exposure. Boundary. Pain control matters. The risk increases with chronic daily use, not short post-operative treatment. 6. Certain antidepressants, older tricyclics. Examples: amitriptyline, imipramine. These drugs have strong anticholinergic effects. That makes them particularly problematic for memory. They are still prescribed for pain and sleep, not just depression. Their cognitive burden is well documented in geriatric pharmacology. Boundary. Newer antidepressants do not share the same risk profile. 7. Bladder control medications. Many overlap with anticholinergics, but deserve separate mention due to frequency of use. Examples: tolterodine, solifenacin. Bladder urgency improves, but memory and attention often worsen. Long-term observational studies show higher dementia incidence with prolonged use. Boundary. Non-drug bladder strategies exist and are often underused. 8. Anti-seizure medications used for other conditions. Examples: gabapentin, valproate. These drugs dampen neuronal firing. In older adults, this often presents as mental slowing rather than seizure control issues. Cohort studies link long-term use to cognitive impairment, especially when combined with other sedating medications. Boundary. Seizure control is essential. The concern is off-label chronic use without review. 9. Strong antihistamines, often overlooked because they are over-the-counter. Example: diphenhydramine again deserves emphasis. They cross the blood-brain barrier easily in older adults and strongly suppress acetylcholine. Population studies show worse cognition and higher dementia risk with repeated use. Boundary. Newer antihistamines do not carry the same brain effects. Each of these medications acts differently, but when you step back, a pattern appears. They either block memory chemicals, suppress alertness, disrupt sleep, or mask early cognitive symptoms. Yet, to really understand why such different drugs lead to similar outcomes, we need to look at what they have in common at the brain system level rather than at the prescription label. At first glance, this list can feel confusing. Sleep aids, painkillers, bladder medications, anxiety drugs, they seem unrelated. Different symptoms, different prescriptions, different reasons for use. Inside the aging brain, though, they converge on the same vulnerable systems. The first shared mechanism is acetylcholine suppression. This chemical is essential for attention and new memory formation. Several of the medications we discussed either block acetylcholine directly or reduce its activity indirectly. In younger brains, other systems compensate. After 65, that backup is limited. When acetylcholine signaling drops, memory encoding weakens. Information does not stick. Conversations are forgotten. Names vanish more quickly. The second shared mechanism is sedation without rest. Many of these drugs quiet the brain, but quiet is not the same as restorative. True mental recovery depends on structured sleep cycles. Deep sleep stabilizes memories. REM sleep integrates learning. Sedating medications often shorten or fragment these stages. The person may sleep longer, yet wake with poorer recall and slower thinking. Over years, this erodes cognitive performance. The third mechanism is masking of early warning signs. Subtle cognitive decline usually announces itself with changes in attention, word finding, or mental speed. Sedating drugs blur these signals. The brain struggles, but the symptoms are dismissed as medication effects or fatigue. This delays recognition and reduces the chance to protect remaining brain reserve. Another shared factor is stacking effects. Older adults often take multiple medications. Each one may have a mild cognitive impact. Together, they push the brain past a threshold. This is not overdose. It is cumulative load. The result is not dramatic confusion, but steady loss of clarity. Then there is reduced adaptability. Aging neurons recover more slowly from chemical stress. A temporary imbalance becomes persistent. The brain does not reset as easily. Over time, this accelerates decline once cognitive disease begins. None of this implies blame. These medications exist because they relieve real symptoms. Pain, anxiety, insomnia, bladder urgency, these are not trivial problems. The issue is that the brain pays a price that is often invisible until later. This is why geriatric medicine emphasizes periodic medication review, not to remove everything, to reassess what still serves long-term brain function. The key idea to carry forward is this. When different drugs lead to similar cognitive outcomes, the explanation is rarely coincidence. It is system-level vulnerability. Still, understanding risk does not mean abandoning treatment. It means learning how clinicians separate short-term symptom relief from long-term brain health. Medicine always involves trade-offs. That is not a flaw. It is reality. Symptoms demand relief. Pain interferes with movement. Anxiety disrupts daily life. Poor sleep erodes mood and judgment. Bladder urgency limits independence. Medications exist because these problems matter. Ignoring them would also harm the brain. The mistake happens when short-term symptom control is confused with long-term system protection. The brain changes slowly. Cognitive decline does not announce itself with alarms. It advances when reserve is drained faster than it can be rebuilt. Many of the medications we discussed do not injure neurons directly. They lower the brain's operating margin. They reduce how much stress the system can tolerate before performance slips. This is why clinicians think in timelines, not moments. A medication that improves sleep tonight may still interfere with memory consolidation over years. A drug that calms anxiety now may blunt learning and attention long enough to speed decline later. These effects are rarely visible day to day. They appear when the system is already strained. This is also why stopping medications abruptly is not the answer. Sudden withdrawal can be dangerous. The goal is not removal. The goal is periodic reassessment, asking whether a drug still provides more benefit than long-term cost for the aging brain. In clinical practice, this means reviewing medication lists with age in mind, not just diagnosis in mind. It means asking whether safer alternatives exist. It means watching cognition as carefully as blood pressure or pain scores. It also means recognizing limits. Dementia is a disease process. Medications alone do not create it, but they can influence when symptoms appear and how fast decline progresses once the process begins. If there is one calm takeaway, it is this. Brain health after 65 is shaped by many small decisions made over long periods. Medications are one of those decisions, not good or bad in isolation. Powerful tools that require age-specific thinking. On We Care Health, my role is not to tell you what to stop or start. It is to help you understand how systems work, so conversations with your clinician are informed and grounded in physiology rather than fear. Understanding comes first. Decisions follow.